Welcome, everybody. We're going to proceed now with session 2, the changing face of American health and healthcare. Obviously, a very, very large topic indeed. And we want to try to bring back into this conversation as much as possible that other M, the Medicaid program. We had the wonderful first discussion this morning on Medicare. We don't want to forget that Medicaid is also celebrating its 50th birthday this year, and obviously it's got a whole new story to tell as a consequence of the Affordable Care Act. What do we know about the people who are getting health care under Medicare and Medicaid today versus who are the people who are going to be getting health care under Medicare and Medicaid tomorrow is obviously a very important question. And what kind of care they're going to need and what kind of care they're going to get is an equally important issue. As has been said in different ways already, we tend to talk about a lot of this in sort of the top-down way. Uwe Reinhardt said last night, as you heard, you get a lot of points in Washington if you just say things like Medicare is unsustainable. You get equal points in Washington if you just say things like the enrollment is going way, way up in these programs, as if that tells you everything you really need to know about the programs. So what we're going to try to do with this panel is drill down a little bit more on these questions. We obviously cannot answer all of the questions about what is the changing face of U.S. health and health care under these two programs in the future. We can't do that in the hour or so that we have, but we can start to really delve into some of the key issues that we're going to face as we see different populations come into these programs. We're just going to start with a few overview slides here and then move on, and I'll introduce our panelists here in a moment. The changing face of American health and healthcare, of course, it does not look like the two faces of Janus, the Greek god, but I use that symbol to suggest that we had probably a different population in the past 50 years than we're going to have in the next 50 years, and understanding the components of that is going to be very important. As I said, we tend to look at this in a top-down way and talk about just overall numbers of enrollment. And we know, of course, the overall story is with respect to Medicare, enrollment is going up. You can see there by the end of the projection period featured on this slide, by 2050, we'll have 92.4 million Americans presumably enrolled in Medicare. Now, again, this doesn't tell us much about else except that that is the overall number. Just to take that out a little bit farther, I pulled this off of the Medicare Trustees report. You can see just looking out a few years more, if we really want to get to the 50 years from now, which of course would be closer to 2065, there you can see we're expecting 102 million. Again, useful to know, 102 million, but again, it doesn't tell us a whole lot about who those people are going to be. We also know this famous slide, which is the ratio of the working age population supporting the Medicare program to the elderly population and others who will be receiving Medicare, and we know that that ratio is going to be changing dramatically. But again, it doesn't tell us a whole lot more about the people who are going to be getting the care, and it certainly doesn't tell us anything about the kind of care they're going to be getting in the future. If we look at Medicaid, again, we know something about projections of enrollment, especially under the Affordable Care Act, and we know Medicaid is going up, and as you can see there, certainly by the end of the projection period is going to be close to equal in size to the Medicare program. And also, this is hot off the press, these are the numbers, the new numbers that the Congressional Budget Office put out earlier this week, projected enrollment in Medicaid and CHIP as a consequence of the Affordable Care Act. And you can see where CBO at any rate is expecting 11 million enrollees, ACA expansion enrollees in 2015, 13 million beyond that, and et cetera, et cetera, et cetera. Again, useful information, but it doesn't tell us a whole lot about who is going to be coming into Medicaid. We do know, anecdotally, a lot about those people. We know just by virtue of the fact that of who was left out of Medicaid historically. A lot of these are going to be adults with non-dependent children. A lot of them are going to be people who have multiple morbidities, including mental health needs. But we also know anecdotally that a lot of people now eligible for Medicaid are low-income, healthy people who are just a lot of people starting out in their careers and working, if not full-time jobs, odd jobs, not much income. And that also is changing the face of Medicaid quite dramatically in some areas of the country that have moved ahead with expansion. So, as I say, we know a little bit, but not a lot, and that's why we're going to have this panel with three terrific discussants and presenters with us. You have very extensive bios of their extensive careers in your package, so I'm not going to go over all of that. I will simply tell you we're going to be hearing from Jennifer Ortman, who's the chief of the Census Bureau's Population Projections Branch, giving us a little bit more a feeling of who is going to be in these programs as we see the changing demographics of the country play out. Jennie Hansen is the CEO of the American Geriatrics Society and is going to be talking about some of the new care models that are evolving to some of these new populations. And then we're very happy, of course, to be joined by Marilyn Moon, known to everybody involved with NASI, an Institute Fellow and the Director of the Center on Aging at the American Institute for Research. As before, we're going to hear presentations from each of these folks. Please, as you hear things said that you want to drill down on in questions, please go ahead and scroll out your questions at that point and hold them up. And we have a couple of people circulating to collect them so that we don't just have a flood of questions come in at the end. We would like to try to collect questions all along the course of the morning. With that, I'm going to turn the podium over to Jennifer Ortman, and take it away, Jennifer.
Okay, thank you, Susan, and good morning, everyone. As Susan said, I'm Jennifer Ortman. I'm with the U.S. Census Bureau, and I've been working on the Census Bureau's projections for about 6 years now. And there's my first slide. So today I'm going to talk to you about results from our 2014 national projections, which we released just last month. So this is fairly new data for you to be looking at. And I'm going to talk about trends in population aging that our projections show for the nation. So this presentation will give you some context of where we think the population might be going and the trends we expect to see in the next few decades. So between 2014 and 2060, the nation's 65 and over population is projected to more than double, increasing from 46 million in 2014 to 98 million in 2060. By 2030, 1 in 5 Americans are projected to be 65 and over. That's just over 20% of our total population. And the growth of the older population, not a big surprise, I don't think, to this audience, is going to be driven by the aging of the baby boomers. The baby boomers started turning 65 in 2011, and by 2030, they will all be 65 and over. The proportion of our population that is 65 and over is projected to remain at just above 20% between the 2030 and 2060 period. So here I'm showing you the percent change in our population size by decade. The blue bars show you the projected change. Well, the first bar is the actual observed change last decade, but that's for the total population. And the red bars show you the observed and then the projected change for the 65 and over population. So you can see last decade, the US population grew by about 10%, and our population is projected to grow much more slowly looking out into the future. If we look out to the 2050 to 2060 decade, we're projecting a percent increase in the total size of the US population of just 5%, so half of what we saw last decade. In contrast, when you look at those red bars, the older population grew by 15% last decade, and it's projected to increase by almost 40% this decade, and then another 31% between 2020 and 2030, so much more rapid growth for the older population. The older population is projected to be the fastest growing age group between now and 2030, growing faster than children or than adults that are under the age of 65. Once the baby boomers have all reached that 65 and over category, this growth is projected to slow. By the 2040s, we're projecting the growth rate for the older population to have dropped back down to a rate that is similar to the rate of growth for the total population. So growth is projected to increase for the older ages in the last decade. You might notice a little uptick again in that red line, 2050 to 2060, and that's when that baby boom echo, kids of the baby boomers, that's when they're going to be hitting and moving into these age groups. So it's not just a story of our population getting older, but our older population is getting older, and I think that's a point of particular interest to this group. So when we look, and these bars are just showing you that within the population 65 and over, what percent is in the 65 to 74 in the red, and then the darker orange is the 75 to 84-year-old age group, and then the kind of pale orange peachy color is the 85 and over, the oldest old. And we can see between 2014 and 2030, we're seeing a shift. So right now, most of our older population is in that 65 to 84 age group. After 2030, we're seeing a jump in the proportion of the population that is 85 and older. And by 2060, 1 in 5 older Americans, 20%, are projected to be 85 and over. And it's particularly interesting to note that trend because there's a difference in the type of care and program needs for the older segment of that older population and then what those who are 85 and older, what their demand and need would be. So I hope some of you may have seen dependency ratios before, but I'll spend just a moment to give you a little explanation of what these are for those who aren't familiar. So these are projections of the total, the youth, and the old age dependency ratios for the United States. Dependency ratios offer another way for us to examine our changing age structure, not just the percent in a given age group, but how those age groups, the size of those groups relate to one another. So here we're looking at the younger as well as the older population relative to the size of the population in the traditional working ages of 18 to 64. You can define the working age however you like. Some people use 20 to 64. Some people use 15 to 65. We're using 18 to 64, or 65, or 64, sorry, here. So dependency ratios are an indicator of the potential burden of the dependent, the older and younger populations on the working age population. We calculate these ratios by dividing the number of people in the dependent age group by the number of people in the working ages, and then we multiply by 100. So old age dependency is a ratio of individuals who are over the age of 65, 65 and over, relative to the working ages. The youth dependency is the ratio of those under age 18 divided by the size of the working age population. And then total dependency is if we just sum up the youth and the old, this gives us the total ratio of the dependents, the older and younger, relative to the working ages. Okay, so now that I've gone through the explanation, what are these dependency ratios telling us? Well, if we look at the old age dependency ratio, that's that red line on this graphic, we see it's projected to increase due to an increasing share of our nation's population that is projected to be 65 and older. You can note that the old age dependency ratio is actually projected to surpass the youth dependency ratio in 2033. That's something I certainly haven't seen in any dependency ratio graphs I've ever looked at. The old age dependency ratio is projected to increase or continue to increase after 2033, while the youth dependency ratio is projected to decrease slightly. And the increase in the old age dependency ratio is projected to drive the overall increase in the total dependency ratio. According to our projections, there will be 76 people under the age of 18 or 65 and older for every 100 individuals in those working ages of 18 to 64 by 2060. This is up from a total dependency ratio of 60 in 2014, so going from 60 to 76. It's a big increase. Okay, something that sometimes gets a little bit of time when we're talking about the older population is the sex ratios or the percent female. So if we look at the percent female or size of the male versus female populations in these age groups. So here you can see percent female for the total 65 and older population as well as the individual age groups within that population. And it's always been the case that there are more females than males in our older population. Female life expectancy has long exceeded male life expectancy, resulting in women outnumbering men in the older age groups. The gap in the number of women and men is expected to narrow in our projections due to a more rapid increase in life expectancy that is projected for men compared to what we're projecting for females, for women. So as a result, we're seeing the percent female is projected to decrease over the next several decades, particularly for those 75 and older. So In 2014, 56% of the total older population was female, and this is projected to drop by 1% to 55% in 2060. But then when we look at the 85 and over, we see 61% were projected to be female in 2060, which is down 5 percentage points from 66% in 2014. Okay, the US population is also projected to become more diverse. We're getting older, we're getting more diverse in our, these projections. In 2014, the total US population, and that's the blue bars on this graphic, is projected to be 38% minority. And we're projecting the United States will become majority minority between 2040 and 2050. This is when no race or ethnic group will have a greater than 50% share of the total population. While the older population is not currently as racially or ethnically diverse as the younger population, and the older is shown here in the red bars, it is projected to experience a substantial increase in its racial and ethnic diversity over the next several decades. The population 65 and over is projected to be 45% minority in 2060, and this is up from 22% in 2014. Okay. So population aging, this isn't something that's just happening in the United States. It's something we're seeing happening around the world. So here I'm showing you projections of the population in selected countries. I'm pulling data from the Census Bureau's international database. If you didn't know, we compile estimates and projections for all countries in the world, not just the United States. In this figure, you can see the bars represent the percent in each country of their total population that is projected to be 65 and over. So the results from 2014 are shown on the left, and results for 2050 are shown on the right. And please note that I use data from 2050 here because the international database only projects the population out to 2050. So a few highlights to talk about here. Between 2014 and 2050, the percentage of the world's population that is in the older ages is projected to double from 8% in 2014 to 17% in 2050. And despite the increase in the share of the US population that's in the older ages, our nation is projected to remain one of the youngest developed countries in the world. By 2050, Japan is projected to have 40% of their population in the older ages. If we look at Germany, Italy, Spain, and Poland, they're projected to see nearly 1/3 of their populations in that oldest group, 65 and over. In contrast, just 20% of the US population is projected to be 65 and older. We can also see, if you look toward the bottom, if we compare the US to the largest developing countries, China, Indonesia, and India, that the US currently has a larger share in the older ages than these three countries, but in 2050, China is projected to have a slightly larger share of their population, 65 and over. So I will wrap it up there. I had a couple summary slides if I had time, but basically we're getting older. We're seeing an increase in our older population, and I think it's particularly noteworthy that we're seeing not just aging of the population, but aging within that older population. So I'll leave that up with our website and my contact information while we switch to the next speaker.
Well, thank you very much. I'm going to actually bring us kind of really from the demographics down to the ground game in terms of what happens with who's going to be there to care for individuals. So I'll go through a set of slides that actually takes the demography a little deeper with some context, as well as thinking about the prepared workforce as we know it today, and what is a situation where many of us professionally wring our hands about it, but there are solutions and options that we must take on now and are taking on now that could make a really big difference. So there are a couple of slides that I have here just to re-emphasize once again what was pointed out before in terms of the numbers. And I think that slide just didn't roll well enough. But the important thing that I wanted to note that it's really in addition to the functional cognitive issues and the medical problems. The group that really I'd like you to take a focus in thinking about that have oftentimes caused a lot of us who have grandparents and parents thinking about the people who are growing at 85 plus. And this is the population that's growing the absolute fastest of our group. And what makes this really important to think about is the workforce. And the 85 plus population is really representing a fair part of the people that was spoken about earlier with the multiple complexities. But in addition, something that has not yet been mentioned yet is the fact that we know that people living to this age have anywhere from studies showing 40 to 50% chance of developing Alzheimer's condition. So you take that cognitive component and really have a major multiplier effect here. And so the formal system has really thought of having geriatricians and psychiatrists in the physician world to be part of that team of individuals who deal with it. And I just wanted to point out in the next slide also is what the ratios are. I don't know if you realize how many physicians there are in the country right now. There are about 800,000. So there are 800,000 physicians, and there are approximately about 7,000 geriatricians sprinkled among them. What's even more severe is we have about 1/4 of geriatric psychiatrists who are really prepared to care for individuals currently. And neither group is growing with any kind of speed. I mean, they are actually kind of funneled from primary care. We heard earlier that primary care is not a large number. But the ability to think about even what we have today, we have 46 primary care physicians for every 100,000 individuals, and we have 65 or 66 specialists, medical specialists for the 100,000. So you look at the people who are most specialized in this complex population, there's some real challenges that we're facing here. So if I were you, and I've actually been doing this, I've been gathering people who are younger than me, who are in these specialties, and I am going to be hopefully more ready to go. Because this gives you a map of where the green covered states are the ones who have a better ratio of geriatricians than you saw earlier. But the rest of the country is really underfunded, so to speak, in terms of that personnel power in that area. So this gives you a sense of people who are most knowledgeable about these multiple complexities. The whole pharmaceutical components that you heard about are far and few between here. The thing I wanted to let you know that the other disciplines who are trained are also quite few. There are about 700,000 pharmacists, and of the 700,000, there are about 2,500. Now, this is a specialty for all of you who are thinking about your parents and all. If you haven't found a geriatric pharmacist, I definitely find one. This specialty is one of those areas in tandem with, say, nurses, nurse practitioners, and physicians. Pharmacists really can help you navigate the 30 or 40 medications that one of the earlier speakers spoke about, because a lot of the issues that older populations with complexity face are sometimes iatrogenically caused by the multiple medications. Social workers don't even have a number on individuals who are specialized in focused on older populations with complexity. And even for nursing, the whole area of nursing, many nursing schools only now have ramped up their curriculum. And unlike a physician curricula, there is not, if you're lucky, you may have 1 month of geriatrics training in the course of a medical school. And it's interesting, I noticed that AAMC has a booth here, and they point out that in a matter of really another 10 years, they're going to be shy 130,000 physicians. But what's interesting is their training doesn't include thinking about complexity and an older population. So that's kind of the landscape of the professional workforce that we're thinking about that already. This doesn't speak to some of the other specialties of dietitians, occupational therapy, and so forth, but these are the ones that you think about most. And one of the other elements, and this is a chart that is from the census materials, but done by AERP. I know that Don Redford, Ari Hauser, and especially Lynn Feinberg are here to really think about some of the data that you heard earlier on the available population growing in these areas and what how prepared caregivers are. What's interesting is that little red top line on both sides represents the 85 plus. The darker blue represents the 65 to 85, and again, the 65 and under are below. This just shows you another depiction of that number, but the population at that red bar grows by 200%, whereas the darker blue bar grows by 79%, and the regular blue, royal blue, is 17. So you start to see this is the shift of longevity that we have. So what do we do about it? Rather than, I think we've known this. This is factual stuff. This doesn't change just because of policy. People are living longer. So what we have to do is really think about that there needs to be a real change of game here. The way we're doing this, I don't see how the physicians are going to pump up 130,000 more physicians in the next 10 years. Right now, geriatrician fellows come in about 270 per year. So, the numbers are the numbers. So we have to really begin to think about how do we do this differently and approach this. So in addition to the models of care, which we'll talk about a little bit, but the whole area of technology is there. And there's pluses and minuses about how we talk about technology. I'm really glad that the President's Council Advisory Group on Science and Technology is taking this up. Industry is coming into this. The robotics right now, Japan, that has a very significant aging population and has not an immigration policy that brings in, allows people to come in, are beginning to use this. Many people have been using technology, whether it's a health buddy system that was used 20 years ago to ways to have a chance to do online communication much more safely. And it's not only the physical care. Given the fact that people have cognitive issues, the patience of robots, of answering the same question, going through the same conversation, is something to really begin to think about for this. The other thing I just want to quickly point out is that one of the things that we're involved with is looking at the ways that the fact that geriatricians are so few and far between, but there's still, 750,000 physicians, others, and nurse practitioners. How else do you do this? So there are two things that I wanted to point out. This is a horizontal intervention, and that is we've teamed up with the American College of Surgeons to talk about best guidelines for surgery for geriatric populations. We've teamed up with the emergency medicine folks to come up also with guidelines relative to this, along with the nurses. So the ability to infiltrate horizontally is one thought. And right now, as of just this month, the Robert Wood Johnson Foundation actually came out with this whole discussion about how nurses are actually number about 3.1 million nurses in the country, how that could be possibly redeployed. And then the other a few things I just want to do toward the end here is realizing, care, quotes, or health is actually coming from where people live, not just the institutions. So I wanted to point out that in Vermont, they have a CMMI grant to really think about how they can do this from the housing perspective, not with heavy-duty professional proportions. These are people who are not physicians, not nurses, and have a huge impact on readmissions. And then also that the YMCA is now a part of a CMMI grant to deal with obesity and diabetes. Black churches in Memphis, Tennessee have done this with readmission. It's going to be coming from the outside. And so in summary, you know, there's bad news, there's hopeful news, and there's a way that we prepare very differently. One is we know that there's a shortage fact. We know that there are other developments, both technology and business, coming in. There are, one of the publications that we got was the healthcare new publication. They talk about docs on demand, which is a whole different way of thinking about the marketplace access. Widening the current professional preparatory training, GME for Pete's sakes, is primarily Medicare money, no accountability for looking at older populations' competencies. Reframing the healthcare workforce to go beyond the licensed guilds that we think about. And then the fact that we really have to include our families as part of understanding the family caregiver, the family care partner. I know my colleague Lynn Friss really wants us to not start using the informal family informal system, because they are a very formal part of people's lives, and I think all of you who are family caregivers know that. So thank you very much.
Good morning. Jennifer and Jennie both set me up very well this morning. Jennifer told you a lot about the statistics and the numbers of folks coming in this tsunami that we're looking at. And Jennie talked about the challenges of what she called the prepared workforce. I love that term because I'm going to talk about essentially the unprepared workforce. And that is individuals themselves and their families. When we're thinking about moving forward and trying to deal with these challenges, we have been already talking about, in many instances, the issue of consumer-centered care, consumer-oriented care, et cetera. And I want to put that a little bit into context and help us think about that this morning. There's lots of lip service currently being paid to the whole notion of consumer-centered care, although I sometimes smile and sometimes grimace when I hear it because I think it's used in better and worse ways in different instances. My least favorite way is more conservative types who like to talk about consumer-centered care, meaning more skin in the game. If they just had more dollars at stake, people would be better consumers. We can all understand that, and that would be the way to move forward in terms of reining in the costs of health care, et cetera. Most seniors have a lot of skin in the game, upwards of around $5,000 a year on average. That's pretty much skin. They're already dancing around in those hospital gowns with the open backs. I don't think that they have to have a whole lot more skin. I always used to imagine a cartoon, and I never saw one, and so maybe I'd find somebody could draw it someday, of the guy standing with, holding the little gown in front of him and saying, "Do I have enough skin in the game yet?" To others, it means offering up lots of choices among plans which beneficiaries can use to make decisions about the way their care will be delivered. And we're seeing more and more of those, as actually Medicare Advantage is doing, I think, a little better than it used to in terms of offering up private options. And certainly the number of drug plans that are out there for individuals are legion. But that also adds to the complexity that individuals must face. And it's much easier to choose those plans and be involved in those choices when you're not facing healthcare problems. So the 65 to 69-year-olds, we should expect to be more active in that regard, and indeed they are. We also know that people don't seem to like choice all that much, since the evidence is if people find a plan, they tend to stick with it, even as that plan deteriorates over time. And people are at a disadvantage, so it's something to think about. Not only just older the very old, but even savvier consumers just can't be bothered, and particularly if they're facing a healthcare crisis. Not only do they not want to be bothered, but in many cases it would mean disruption in the care that they're getting because they'd have to change providers, and that's often very challenging. The third way in which I think people talk about consumer-centered care, and it's important to consider going forward, is in terms of delivery system reform. We hear a lot about patient-centered medical homes, for example, but I've heard, unfortunately, a lot of providers who are interviewed about that say, well, I know what's best for my patient, so it means I'm just spending more time holistically looking at the patient. And that may work in many instances, but I think the notion of getting consumers more involved is an important one. So everywhere you look, consumers are going to be asked to be making more decisions and to be more involved in the process. That's going to only expand over time. But in practice, there is little support or information really provided to help people work their way through these complex systems. And when people get sick, each of these areas is compounded and makes it more difficult. So a new generation of consumers will be coming along, and we can all hope that everybody is suddenly much more successful at managing the healthcare system than so far. But early efforts at looking at the ACA don't make me incredibly confident that people in their 40s and 50s are necessarily savvy consumers yet either. They're not being given very much help. And it may well be that people are going to reach 65 and act as though some of my colleagues have that I've known who've said, thank goodness now I'm 65, I can be in the traditional Medicare program and I can stop worrying about all these choices and things that my employer makes me face. So I don't think that we necessarily can assume that just because the population for a while that's turning 65 is going to be dominated by younger members of the 65 and over population. There is not much evidence that health literacy is really very strong much of anywhere at this point. Health literacy is a lot more than just standard literacy. It means understanding numbers, it means understanding healthcare jargon, and it means a willingness to tackle things that are often pretty uncomfortable for individuals to think about. People get very nervous and skanky when you ask them to talk about things that they may not want to talk about, like what do you want to do at the end of your life? How do you want people to care for you when X or Y or Z happens? The context is likely to change in the next few years, I think, making things a little bit more complicated. First of all, new payment systems are probably done deals. They are going to come online. We are going to see Medicare making additional changes, which will make the traditional Medicare program hopefully better, but undoubtedly more complex. You're going to have to worry about some of the incentives that are going to get set up. For example, if we bundle payments so that people who are leaving the hospital and need post-acute care, skilled nursing care, home health care, outpatient therapy, when we pay in a bundle, you really have to worry and be concerned about who's going to be really in charge. If the hospital's in charge, the decisions are likely to be a little different than if the skilled nursing facility is in charge, or if somebody totally separate is in charge. All of them will face different incentives, and that means people will need to think about that. Now, it can have some real advantages as well if there truly is coordinated care. Speaking personally as someone who has become an unprepared caregiver in the last 6 months, coordination is pretty crappy out there at the moment. One area of the healthcare system doesn't have a clue what another area is doing, even when you think there should be smooth handoffs happening. So whenever the system changes, as it will, people need to begin anew and think about things differently. And so that's going to continue to be challenging as we struggle with healthcare, I believe, for the next 15 or 20 years in terms of figuring out how to wrestle it into some better situation. Some groups are getting out of the business at the same time we're talking about this. More and more employers are leaving individuals to make their own healthcare decisions and not being nearly as active with either retiree health or with the health that they have to deal with for their current employees. And as we heard from Jennie, the labor force isn't particularly ready to handle this. And family support is going to be less available in the future in many cases. The number of children of seniors is going down. That's part of the reason why the dependency ratio is changing. And people are much more mobile than they used to be, so they're likely to live in different areas. I think meaning some of the technology becomes ever more important. So let me talk just for a few minutes about what needs to be done. First of all, I think we need to pay special attention to programs for helping beneficiaries. We need to improve them, spend more money on them, not expect, for example, as in the case of the SHIP programs that provide counseling, that it all be funded by the presumption that there will be oodles of volunteers to take care of this problem over time. We need to build in a consumer role in these new delivery system models and be very active about that. There needs to be demand for consumer participation, but there also needs to be a facilitation of that consumer participation. It is not enough just to put someone on a board and expect everything to work out well. There needs to be special attention to the coordination of care for those with complex problems. Someone needs to understand how everything fits together. Someone needs to be paid for that in our healthcare system. That may be part of these new delivery systems. It may be something quite separate. And we need to address the issue of long-term care in all of this that we tend to ignore when we talk mostly about Medicare. Medicaid tackles that, but only for a small part of the population. I will leave you with one last thought, and that is one of my favorite talks from Catherine Hawes, who many of you know, about long-term care, was that her greatest fear was when a young woman in a very snappy suit and a very fancy briefcase came into her office and said, "I've determined one of the greatest ways to make money in the future is to be a care manager for seniors, and I'd like to have your help in setting up that as a new business model." I think we have to think very seriously about how much we want to turn this over to the for-profit center. That will mean people like me will be able to find sources of help, but it doesn't portend very well for people on more limited means. And I would urge that that's something that NASI and other groups can think more about in the future. How do we really prepare to make consumers prepared caregivers as opposed to the unprepared workforce? Thank you.
Great. Well, thanks to all three of you. So just to briefly recap of what we've heard from these three terrific presenters. As we heard from Jennifer, we know we're getting older as a country. 1 in 5 Americans 65 and older by 2030. Even though the population is growing more slowly overall, there's very rapid growth of the elderly population. And the older population is getting older itself, as we heard, with the 85 plus share of the population growing the fastest. She mentioned the dependency ratios shifting both at the young end and at the low end. Now I know why I'm so tired, as I'm a person in the sandwich generation experiencing those shifting dependency ratios, as of course are many in the room. We know that this older population is going to continue to be more female than male, as we heard, and more diverse, with the majority population becoming, the U.S. population becoming a majority-minority population sometime between 2040 and 2050. Striking, as you said, Jennifer, that amid all of this, we're still going to be a relatively young population compared to others in the world. So, you know, we think we got problems. Let's think about China. Let's think about Europe with even much older populations than we are going to have. Now, as you heard from Jennie, we have just a complete mismatch looming between these folks who are going to need care and who is being prepared to care for them, whether geriatricians, geriatric psychiatrists, geriatric pharmacists, et cetera, et cetera. And as you heard from her, we need a real change of game here. I'm not sure we're all going to be sitting in front of robots who are patiently answering all of our questions over and over again, as Jennie said, but technology is going to be one way to deal with this, and you heard also about some other innovative models that are potentially being tested out in various states that may offer another solution. Marilyn then talked, of course, about the unprepared workforce, as she has found herself, as she said just recently with respect to being a caregiver, and new choices having to be made by people going forward among new delivery arrangements, coordinating care for people, building that greater consumer role in these delivery system models as she laid out could be an extreme challenge for the people who have to be making these choices. So we have a lot on our plate. To take some of the questions that have already come in, Jennifer, here's one for you. In 2050, when we're at this majority-minority population, do we know much about what will be the breakdown of racial and ethnic groups within the majority-minority population? Hispanics, Asian Americans, African Americans, Native Americans.
Yes, is this on? I can't. Okay, sorry, I wasn't hearing it. Usually I can hear myself echoing. So we do project our population projections have race and Hispanic origin detail in them. I don't have the exact numbers in front of me, but just to give you highlights, when we're looking at the racial and ethnic makeup of the U.S. population in the future, right now the non-Hispanic white alone population is considered the majority. They have around, I think it's just shy of 70%, if I'm remembering correctly, of the total population right now. That's going to fall to just below 50% over the course of these projections. And some of the groups that we're seeing, the largest groups, Hispanics, are projected to become around 33%, I think it is, so about a third of our total population is projected to be Hispanic. We're looking out to 2060. The Black population, as I recall, is just shy of around 15%. If you're looking at the non-Hispanic Black population, so they would be another one of the other larger groups. The Asian population is projected to see its population double, so they're projected to reach around 8%. And the two or more races population is another of the rapidly growing populations, still a small total proportion of the total. But if that hopefully gives you a sense of some of the racial data. And we do have our projections and summary tables on our website, so if you do want some more information on that, that's a great place to go, or just send me an email.
And what do we know with respect to the older share of the population and the minority share of the older population? Is it going to be roughly the same proportions or different?
So the older population, it's a little bit different, but they're following the same trend. So because the older population right now tends to have a higher proportion in the non-Hispanic white alone category, for example, and in the projections, it's almost as if they're lagging behind the total population a little bit. The younger population is the most diverse in the United States. And then as you look toward the older population, that's a group that tends to be predominantly non-Hispanic white. But as the younger generations start aging forward, we're going to see that diversity start to reach into the older population. And that's where that projected diversity is coming from. As the younger generations are aging in to that older population, we'll start to see that shift. And eventually, if we were going out further in our projections, we would start to see things like the older population reaching, 1/3 Hispanic, that sort of thing. So as we go out a few more decades, as we start projecting further and further, we'll start to see that trend play out.
So this is a question I think we will direct to Jennie. Absolute number of providers is necessary to talk about, but it's not sufficient. Given these changing demographics, isn't it important to talk about the skill sets among various provider groups, like cultural competency, the ability to meet language needs, especially in home and community-based settings, long-term care settings in particular?
There always is a need of how to understand how people make decisions, how people receive health, even now, and certainly going out in the future. I also do know, though, and again, I may be a little bit on the edge of saying this, by saying this, is that there are some technology ways to communicate now in ways that we weren't able to do before. I think it's improving tremendously. So it doesn't address the cultural components of it, but there are language abilities to communicate differently. So I do think that this is true for any healthcare provider, to have a much more anthropology perspective to care as a whole, because you know, different parts of our country, people make decisions differently. So it's a framework, number one. There's some technical opportunities for greater skill. There are care providers now that are doing telecare, not even from our own country, but from other countries. So they're just different methods that are possible. So when there's a real problem, somebody will invent some solution to do it. So it's, you know, there's angst here, but there are possibilities of our creativity.
Great. Here's one we'll pitch to Marilyn. More elderly, of course, means more deaths. How are we going to evolve care to better address end of life? And what does value-based purchasing mean in the context of end of life?
Ooh. Clearly, end-of-life care ought to be something that we talk very seriously about. It's one of the things that I know people are not very good at addressing in many instances. My husband spent over a month in the hospital and an acute rehabilitation facility, and I think the number of times anybody ever talked about advance directives or anything of that sort was only at admission and only once or twice, perhaps, during that whole period. Now, he wasn't near death, but it still is something that the healthcare providers seem very uncomfortable of even addressing, which I think is interesting. And I think the American population mirrors the healthcare professions as well, in the sense that this is something difficult for people to do. I think we're going to have a much healthier conversation about that before we expect then care to change in response. Value-based purchasing, the way in which I think it's promising is if it teaches all of us to be better at saying what kind of care we want in what kinds of situations and in what kinds of settings, and that extends to end-of-life care as well. So hopefully, as we all train ourselves a little bit better to ask questions and to get more involved in healthcare, then some of the end-of-life discussions will become a little easier as well.
Jennie?
I just wanted to offer a metaphor for the value-based care side, and I'll have one other comment about end of life. The value-based care, you know, the old method is, say, when you go to an institution and they are providing you care, they want to do their best, ideally, even though it's very oftentimes checkered in terms of coordination. They want to do their best. But the old method is, once you get wheeled out of those sliding glass doors, you're on your own, okay? So that's a metaphor for me for fee-for-service. The new value-based care is, after you get wheeled out, they're going to worry whether or not you're going to take your medicine, and hopefully that you don't return within those 30 days. They have to care for you as a population and a person that is different. So the value is, after the technical acute care they may provide you, they want to see you be stable, because you being stable is actually of great value to everybody. One quick comment about end-of-life care, or just, how many of you have read Atul Gawande's latest book?
Being Mortal.
Being Mortal. If you haven't, I commend that to you, because it really talks about this in a much broader way. And the broader way is having people understand not just what their wishes are so you can complete a form, but have a thought of expressing what's important to you and what are your goals. When you change that conversation, you get to a different place. And it then really designs the care and the wishes of things that happen. And there's good empirical information from the New England Journal of Medicine about people with lung cancer getting this palliative care about their wishes. They lived longer and it costs less. And, you know, it's just like everybody won on something like that. But you have to frame the conversation differently and not just forms.
So question for Jennifer. How does income and rising income inequality play into the changing face of Medicare?
That's not something I can speak directly to. Our projections are based on assumptions about future rates of fertility, mortality, and migration. We're not delving into the world of economics with our projections. The Social Security Administration does produce their own projections, which I'm assuming a few of you have probably seen the work that they do. And they are factoring in some of the economic factors into their projections. So I would point you to those as a resource for that topic.
Okay. Marilyn?
Susan, I just mentioned briefly that if you look at growth in income, it looks pretty good for the 65 and over population. But if you break it down by quintiles, for example, it doesn't look so good. It looks a lot better for the top quintile or the top decile than it does for everyone else. It is also the case that if you then pull out Social Security, it looks even worse. So Social Security has done a great deal in reducing some of the inequality that it would otherwise follow people from earlier life differences when they become 65, but it doesn't make them really well off. It just helps with the floor substantially.
And I think it's still the case that for the elder population, for a vast majority of them, something like 80% of their accumulated wealth, if you will, is in Social Security, not in any other assets. Jennifer, one more on population projections. What assumptions are made about immigration in that aging projections that you laid out? Because of course immigrant populations tend to be younger. I assume you're taking some element of immigration into account, but how?
So there's a couple of interesting points I can bring up here. So first, just how we project immigration. So we of course have a native-born component in our projections, but there's not a lot of migration in or out of the country of the native-born. Most of the migration is of the foreign-born. So what we do in our projections is we actually look at past trends and the rate of people leaving other countries to come to the United States. And then we model that rate out going into the future, and we apply that rate to our international database projections of countries in the rest of the world to get a projection of how many people do we think will be coming in the future. So our projections are grounded in projections of the size of the population in other countries. For demographers, that's a really important thing because we want to make sure that migration is tied to being realistic given what we think growth will be in other countries. So that's how we project migration. And of course, most immigrants really are between the ages of 15 and 40. So immigrants are generally younger, but once they arrive in the U.S., some do leave at some point, but many do stay. And as they age, and in our projections, we actually started projecting the population, including a foreign and native-born component in our projections. Those results are available on our website. So what we do see is the foreign-born population, those who stay once they migrate to the United States, they're getting older as well. And so aging is not just for the native-born population. There are foreign-born residents who will be aging and entering that category as well, which of course will have issues when if we're talking about language and other social and economic indicators. The foreign and native-born component there will be very important for that.
So we have two different questions that have come in that represent a kind of an internal debate among these questioners. It's sort of like an instant crossfire. One asks, what can be done to increase the number of geriatricians, Jennie? But the other asks, why do we need specially trained geriatric caregivers? Aren't all the current caregivers patients, let's see, as all current caregivers' patients will invariably age? I guess that means providers are just going to adapt because they're going to be treating older people.
Well, I'll take the second one first, and why not? This is true. There are, let's see, probably over 140,000 physicians who are primary care. But what happens is, when you describe that person who gets 30 medicines and all, that's actually prescribed by people who happen to be taking care of older people right now. That's not necessarily the best behavior. That is something that they are doing right now, but just doing what you're doing doesn't mean that you are based in your practice or frankly competent in this. People don't recognize some of the things that happen with people, that fevers are very different with older people. Pneumonia shows up very different. The ability to make sure that people don't experience delirium, which is a very devastating clinical condition. People don't recognize what's called hypodelirium rather than hyperactive delirium. So there's a lack of that kind of scientific knowledge. If you didn't get it in your curriculum, you don't get it in your practice, you practice and give your basically guild best practice for the person, you don't realize there's evidence to do something differently to help people prevent falling into these areas. Why do we need geriatricians? I think we need people who are specialty focused because there are areas of great complexity when somebody has dialysis along with congestive heart failure, along with diabetes. People are parts people in the way we have trained. They are not general contractors. So we need smart, skilled general contractors when you have a complex case involved. And we call that geriatrician in this case because it happened to be the older people, but we need people like that in other specialties. So that's why we have colleagues now in surgery and emergency medicine, ophthalmology, who do this. But somebody, if you're building a house, you can have a great plumber, you can have a great electrician, but if somebody's not looking at the total joint fix, so to speak, you know, things will fall apart.
So we'll close with one final question that is workforce related, and it speaks to the need for the home care workforce. As this questioner writes, they haven't been mentioned, but they account for the second or third fastest growing occupations in the U.S. There's a serious shortage, woeful lack of infrastructure to prepare them, or financial resources to support the development. So Jennie, why don't you take that? And Marilyn, I'd love to hear you weigh in on that as well.
Right. Well, I think that I am hopeful that with, first of all, that's a fact of what the person who wrote the question. These are the fastest growing jobs. There's about 1.5 million jobs in home care, nurses' aid, and personal care coming down the pike. But I am hopeful that with the new payment systems, when you end up bundling money, the ability to help somebody stay in best steady state oftentimes are not the real specialists. It will be people who are helping on the day-to-day level. The value of people who are in this category of workforce has been so underappreciated for so long that the fact that their role is absolutely crucial to have an older person who's confused, be willing to eat, be willing to walk. It's not the geriatrician himself or herself doing it. It's somebody who's going to be spending those 22 hours in the day to help somebody be stable. New payment systems will afford a different recognition of this workforce.
I wish I was as optimistic as Jennie about this. I agree with her that home health is a really critical piece of the puzzle of providing care, and it is often underrepresented. It is not really paid for by Medicare. The home care that comes through Medicare is very limited in nature. It is a therapy, nurses' visits on a very limited basis, and it assumes essentially that either there's a caregiver or other paid folks who don't come through the Medicare system out there making that possible. You simply cannot stay at home and be independent if you are in great need with 2 home health aides coming in 3 times a week. That just does not do it, and that's not what's needed. So until Medicare and Medicaid can be thought of together, and or we think of ways in which we're going to pay for these bundles that go beyond just the strict limits of what Medicare will pay and what it thinks it can hold the line on, then we're going to continue to have a problem. The unpaid, I don't mean unpaid, unreimbursed, not Medicare reimbursed home health care world is a very confusing, very complex, and very a disorganized world at the moment that relies lots on other folks putting it together. If you were by yourself trying to do this, it would be almost impossible now without a lot of help from someone else.
Well, for those of you in the audience who are not only NASI members, but also members of what Garrison Keillor calls the Professional Organization of English Majors, or POEM, you will remember Robert Barrett Browning's famous verse, "Grow old along with me, the best is yet to be," to which this panel might reply, well, we'll see about that, or vamos a ver in Spanish, right? It's going to be interesting. And join me in thanking this panel for fleshing out just how interesting it's going to be. Please fill out your blue evaluation form in your folders after this session, and of course all sessions over the rest of the day. Next up on the agenda is going to be lunch, but first we have to clear the ballroom for a short break while the press club staff sets out the lunch. It's a really wonderful time to check out the exhibit lounge next door. You'll find recent publications from Academy members and a variety of displays from sponsors and partners. Please be back here in this room at 11:30 for Sachin Jain and his conversation with Dr. Patrick Conway of CMS at 11:50. Thank you so much.